Okay. Okay, cool. We are back again. And we just went live in the Reddit group. Andrew, again, is a exercise physiologist from Sydney. And we're going to be talking about the wiki that he created and put together to sort of just help guide and steer people towards a better understanding of some of like the more common questions that people have put out there on Reddit. And one of them being like MRI scans. We get a lot of posts online that say, here's my MRI scan. What does it mean? And so he actually put together like a really awesome document that we'll share and go over just that part too. So Andrew, I know it's getting late, but you said you had a good day so far.
Yeah, it's been pretty good.
You know, I said so far, right as I was saying your day is pretty much over. So
It's still going.
All right, let's see. Okay, actually, we're just live on YouTube. Now we are live on Instagram. Just figuring it all out. Okay. All right. So what's your first like take when people start posting MRI images? Like, you know, people have back pain, they get imaging, and their first instinct is they can't really tell what like the medical jargon is or like the impression. So just like what's a quick hot take on like if somebody has back pain and they go and get some imaging and they're kind of panicking and they don't know what to do, what's your first kind of take?
Oh, it's like such a touchy topic because I think there's like some research out there as well. I think if you kind of go into the document, and there's a website called Choosing Wisely Australia, and they kind of do talk about like how imaging itself is generally can't show you the cause of pain, and it's like kind of closer to the bottom there. Oh, yeah, it's like, yeah, that one there. Why imaging isn't needed. Yes. Oh,
Talk
yeah,
about
just go a
this.
little bit. No, go a little bit higher up. I think it's those dot points. Why imaging isn't needed. Oh, you passed it. You passed it.
Oh, I got it.
Yeah,
Here
you
we
got
go.
it. You got it. Yeah, it's that one.
Okay.
Yeah, it's like
Yes.
X-rays, CTs, and MRIs. It's like hard for people to like tell you if you're in pain or not from the imaging. And there's some research also showing that like if you do get imaging and you've been shown all these like big scary words like disc protrusion and everything like that, like it could make you more scared and more fearful of your back because it's like I think my back's even in worse condition because of all these medical jargons on my report, right?
Yeah. So I think you have a distinction between symptoms and medical imaging. And I think like right at the outset of this discussion, it should be noted that like the clinical practice guidelines for like who determines like obviously your general practitioner or your neurosurgeon or specialist, you know, when you have a new onset of back pain, the clinical practice guidelines are moving more towards a conservative approach where imaging may not be needed or necessary right away. And I think it's something like 59% of people who get imaging specific for back pain actually didn't need it right away. um, and so I think talking about why imaging isn't always needed because of this like first step approach for obviously an emphasis on conservative management, but just that, hey, maybe it isn't needed because there is like this 6-week window of time where you might actually improve as long as, you know, you don't have any like red flags, which we talked about in the last video. But it's like these red flags definitely steer the decision making for medical providers to think people should get imaging much sooner, right? So we're kind of moving on to the okay, there are no red flags. Now, why are people not getting imaging right away? That's kind of, I think, what you're talking to is like why imaging isn't needed. So is that number 6 weeks that you've been finding mostly?
Sorry, for like
The
the time frame of like when imaging should be done or shouldn't be done, or
Yeah, so if somebody is got symptoms and the doctor's like, let's just wait, let's try physio, let's try PT. What's a timeline in which they say, okay, you've tried it, now let's go get imaging because you haven't gotten better?
Yeah, I think 6 weeks is a fair call, but it also might depend on like what has been done so far. Is it like proactive therapies or is it passive therapies? And if you've been passive the whole time, it's like let's see if we start being proactive from now. So it's like those weeks might shift a little bit longer depending on like where you're at on your journey.
Right. So if somebody just nothing but bed rest
Yeah,
for
then it's like okay, maybe your 6 weeks start now, even though you've been bed resting for like the past 2 or 3 months, which is
yeah,
like yeah,
yeah. And of course, like general treatments and stuff like that, I think we can talk about it another time. But the imaging, why it isn't needed, and as you were starting to point out, is like you can't necessarily pinpoint pain on a scan. Well, not necessarily. It's like you can't. I mean, you can get imaging, and we can talk about why that is in a moment. But also that uh, because you can't identify pain, you can't really tell from imaging the severity of maybe symptoms as well, just from looking at a scan. So I think we got two. I'm kind of going off, but we got two different ideas where it's like you have somebody who's got pain, and the severity of symptoms don't correlate well to what's actually on the imaging.
yeah. And I feel like there's a few more little things why we shouldn't get imaging. So if you like look at that last document on like the page right now, it's like the title of the heading is I know other people who found changes on imaging of the back. What if I have these changes too? Yeah.
Yeah, so you're saying that if we and then we can maybe go up back to that asymptomatic chart, but it's like no two people are obviously the same. So even this, you could have on Reddit, we find this a lot where people have like similar scans. They're like, oh, your scan looked like mine, but they could have completely different symptoms. So
Yeah.
if we scroll up to that chart, you can run us through that real quick. So how common are my scan findings?
Yeah, so I think like this is just a snapshot of like the table of what they found from a study of like quite a lot of people. I can't remember the number off the top of my head, but I think it's a few hundred people in this study where they're just doing scans on people with no back pain at all. It's just they were trying to find how common is it to find disc degeneration or disc signal loss or disc bulges or protrusions, which is like slip disc and stuff, or even like facet joint degeneration, or even spondylolisthesis as well.
Um, yeah, spondies. This is why people just call them spondies. They're hard to say. So you've got you've basically got an age group and the percent of these particular conditions found in that age group, and that percent is like asymptomatic. So if you, I think the easiest thing to do is like if you just go to 80 years old and you look at disc degeneration in the 80-year-old, there's a 96% prevalence rate, but like asymptomatically, right?
Yeah, and even as early as like 30 years old, it's like 50% of the time, if you toss a coin, it's like you will probably be finding disc degeneration in
Right.
a person who's 30.
So as we can sort of look at the different conditions on the left of the chart and we work our way up from age of 20 to 80, what does that tell us basically about a lot of these issues?
Yeah, so I think pretty much what this table is trying to tell us is like the older we get, the high percent chance we will be finding just changes in the spine. And I think the conclusion of like that little study was like, okay, if it becomes more and more common as we age, it's like we're kind of coming to the conclusion that like, okay, maybe these changes are normal, therefore they're age related changes. So what I like to tell people, it's like, okay, even though that these are changes that we are seeing on like the scans and stuff, we might more so consider them as like wrinkles of time on our disc or whatnot.
Yeah. So it's almost like I think I had a clinical instructor one time say if you scan 100 people at Walmart, 99 of them are going to have degenerative changes. So, and not all of them are going to have symptoms. So that's it's like a nice summary of this chart is essentially is like we expect to have degenerative changes on imaging.
Yeah.
And if you can find high prevalence in asymptomatic populations, you can then make the inference to like kind of jump towards maybe some conclusions you can make about somebody's scan. So a lot of the times people will go onto Reddit and they'll post an image and they won't even talk about their symptoms. They'll just say, "How screwed am I?" Right?
It's, no one can tell.
Which is it, like I don't fault them for this because they are like desperate, right? They want answers, and maybe in the United States there is a little bit of a delay from imaging. We've got a lot of like my charts, so people will get their imaging. They'll actually get the image done. They might get the results 2 days later on my chart, but their doctor might not even be able to get back to them for another couple days. So it's not like I get it. It's not that we're faulting you for wanting to have answers, but without any symptomology or any type of life experience, lived experience rather, about what's going on with your symptoms, we can't even really. I mean, it's kind of like honestly, it's useless information just to even have
Yeah.
like.
Yeah, without your side of the story, it's like scans can't tell us anything. It's like we need your story. Because there are also like cases where person's pretty young. They might be like in the early 20s and they have back pain and the scans actually might come out clear. They're like, how is this possible? So it's like, yeah, it's like I
Yeah,
can't even walk properly. My scans say I'm fine. So it's like,
yeah,
okay, this is like even more evidence kind of showing it's like maybe scans aren't that important. And
yeah,
actually talking to you and getting to know you on like what things you can and can't do is way more important than saying, hey, you have disc degeneration. It's like, and what? It's like I still can't walk around even now I know that I have disc degeneration.
yeah, and it's kind of like this is where I get into where I talk to people and they're like, "Yeah, my back hurts. I guess it's just fact of life. It's just me getting older." And I want to like I posted a meme of like Batman smacking Robin or whatever, and it's like age is not a reason to have pain because you can like if you just like this like these findings were so remarkable because it's like what these people you know like I've worked this is just anecdote. I had a 105-year-old patient that I worked with, and he again I kind of come back to maybe so there was some cognitive stuff going on, like maybe some memory loss, age-related memory loss or dementia, but it's like he didn't have any pain. I mean, just because he's old doesn't mean you're going to have pain. Um, so that can be frustrating to have pain and then have imaging that is completely clear and or quote unquote normal, or like maybe the physicians are coming back and they're saying, oh yeah, like this is a normal scan. Well, it's like, well, I see a bulge. And so when in your mind does imaging, when is it needed? When is it necessary?
Yeah, I think we kind of touched on that last time, but it's more so like looking at these like emergency situations. And
Mhm.
emergency situations only like upgrade or like become an emergency situation from the person's story. It's like, okay, I can't really walk properly. I'm losing
Mhm.
sensation in my foot and I can't really now my foot's starting to drop and drag across the floor from when I'm walking. And it's like,
Yeah.
okay, that's a my alarm bells are going off. It's like, is anything else happening? It's like, oh, now I'm also having problems going to the toilet. It's like, okay, these are more red flags as well. It's like, okay, the alarms are ringing. It's like, okay, maybe you want to see some imaging for like some
Mhm.
really quick, uh, like surgery is probably needed like very soon because it's like these things are kind of scary.
Yeah, yeah, and since that is the, like, 1% of back pain cases, I like to talk about that 6-week timeline part. So to give people and the whole point of this conversation is really to give people reassurance about, A, why maybe their doctor's not getting them imaging
Why
where
they're waiting around? Yeah.
Exactly. I think if you have worsening symptoms, like oh, my foot's a little numb, little tingly, but it becomes more of like a constant numbing, and it's and then loss of some of that power, like drop foot. Uh, there's some type of occlusion or kind of like um, what's another word for occlusion? Block, like in a hose, like a kink in a hose when we're talking about nerves. So I think having that conversation with your doctor, being like, hey, it's it is 4 weeks or it is 6 weeks, nothing's working and symptoms are getting worse, then, but maybe not in that red flag category. I think, having that conversation's good. So I don't want people to think Oh, like just it's a total toss away. But yeah, if you're at that 6 week mark and things are like definitely not better or worsening, it's that's when you're probably going to get imaging, and that's when it's appropriate. Any thoughts?
Yeah, yeah, I think those are like good cases for imaging.
Cool.
But I think like also the reason why they like kind of tell you to wait is that like you might be able to get more value out of different therapies compared to like paying like a couple $100 for
Hmm.
like an MRI, and you might even be on a waiting list for like the MRI as well, depending on where you go.
Yeah.
It's like now
Um,
you're waiting around and super anxious because it's like, okay, my scan will finally tell me what's wrong with me, and
mhm.
you're not really doing anything about it, and you're just stuck in limbo, which
Yeah.
might actually make the pain even worse.
Yeah. And that's a whole nother conversation. Um, but yeah, I think where my mind was kind of going is like, even if you do get a scan too after that 6 week mark, you might still not be a candidate for surgery because surgery is risky, and there's no really guarantee that things will be better. So that's obviously a conversation for you and your neurosurgeon or GP.
Yeah. So I think today we're also gonna touch on like the different definitions of like what do these things mean if it's like not that scary and if they're normal. It's like how
Hmm.
like this degeneration sounds like it's withering away, right? It's like what does that even mean? Yeah.
Yeah, I think everything we let every diagnosis needs like a name. um, and I think the classic conservative treatment approach is like your diagnosis is not necessarily your prognosis, right? So focusing on like, okay, yes, we just established that degenerative changes like disc degeneration or disc bulge or protrusion are all like normal findings. So okay, now let's just focus on prognosis. Is that in the document you want me to point people to, like these where it's talking about
The
um,
normal image findings, I
yeah.
guess. Yeah. It's like we can touch on this a little bit as well.
Yeah. So, um, I mean, degenerative disc disease, that's, if we just talk about narrowing of discs as we age,
It's just mainly like how tall, quote unquote, tall the disc is.
yeah. And then, spacing is narrowed, right? Because as we age, essentially we shrink, right? As people get older, they're like, I've lost a couple inches. Well, your discs, we lose water as we age. And so the hydration of them, causes the height to alter. But bulges, I kind of want to jump to bulges because everyone thinks, oh, I herniated my disc or blew out my back when I'm lifting. And do you off the top of your head, what percent of disc herniations are caused from quote unquote heavy lifting?
Actually, not too sure.
I think it's like it's a single digit. It's either it's like 8, 9% or six. It's like 6 to 9%. Um, and so if that might like surprise people. So I think getting into we're coming up on the 20-minute mark, and we could have a whole 30 minutes just on disc bulges, but genetics play like a way bigger factor, and lifestyle factors alone are much more heavily weighted in my mind, and in the evidence about risk factors for like having a bulge. So um,
Yeah.
that gets into conversations about lifting and things like that and what's safe and what's appropriate. And that's where having an individualized approach, if you do have these conditions with a provider, becomes very handy.
Hmm. Yeah. I think I put like a big dot point there down the bottom. It's just like people who do have like really severe slip disc or like sequestrations. It's like
Hmm.
pretty much the worse the quote unquote worse or bigger the bulge. It's like the percent chance that it will actually like spontaneously reabsorb is like really high. And then if it's just like a slight bulge, it probably will stay like that. Or
Yeah.
has yeah.
Yeah. Do you know what the theory is on why?
What's the theory on why?
On why, like, the worse it is, the more likely it'll heal.
Yeah, what's the theory?
I think I read somewhere that it involves more structures. So it's like it's exiting out into more areas, and so your body's able to get to it. And if a bulge is just kind of like bulging out, it's kind of encapsulated, and you can't maybe get as much fancy medical jargon for chemical mediators and whatever else promotes that healing process.
Hmm,
I think I read
interesting.
that in a study. I read it in a
Yeah.
book. I read,
Yeah, I think I also read a few other or seen a few other articles as well. It's
mhm,
just like I think the very typical one is just like your disc are like jelly donuts. If we
mhm,
bend in one direction, the all the jelly's gonna explode out of
right.
that like gap or whatever, right? I
Yeah.
think there was a study that was like looking at a live MRI
Mhm.
and and like even though the spine was like bending or whatever, the the like actual protrusion kind of reabsorbed, and it's like what the are the current models that are like going everywhere on the internet incorrect, and it might be so.
Yeah, I think there's a lot 'cause obviously a lot that we're still needing to uncover about, like, the specifics for mechanisms and things like that, which, again, not enough time gets
Yeah,
into, um, what's the when you talk about mechanical pain or, the difference between chemical or, like, those sorts of things. I really what's I kind of come back to this idea that it's like it's a whole biological system. So you do have psychosocial factors, you do have mechanical tension at times, chemical irritants at times. It's just sort of all wrapped into one. So um, people get caught up in the specifics of what's causing their pain. But what's cool about conservative management is it's just one big Rubik's cube or puzzle. Maybe is better. It's where it's like, okay, we're going to experiment because no two presentations are really the same.
yeah. So it's ultimately trying to like learn what you, the person in front of us, like needs, and
Mhm,
that will only be figured out like through a little bit of experimentation and testing to see what does work for you. It's like if bending and slouching hurts it more, it's like, okay, maybe if we're a little bit more upright, maybe that will help it. And then if
mhm.
being upright the whole time is really aggravating the back, it's like maybe we can relax and slouch a little bit more. That might be helpful as well.
I call it hanging on your bones. I think I, I keep pulling up all these things. I keep saying there's not enough time because there really isn't. But posture, right, is like too many people are trying to find positions that feel better, but then there's an emphasis on like static posture, and I'm everything feels like an uphill battle when it comes to talking about myths with back pain, and because of that unique individualization, it's like I tell people it's like you slouch, hang on your bones a little bit. It's like give those muscles and things like a break, like those dynamic structures that have like endurance qualities. They do get tired. Then you have like static structures like ligaments and bones, and it's like yeah, like just those can handle some force. So um, coming up on 25 minutes, and we haven't talked about is that pretty much everything that you wanted to mention about scans? It's kind of all over the place. My
Yeah, there's
but
so much to talk about for scans. It's like each little thing can be like a whole talk for
mhm.
itself. So it's like, yeah, we're just like touching the surface on like just these things.
Um, so if let's say a close friend of yours came to you and was like, "Hey, I got this image. It's been 6 weeks. I'm slightly better, but things are not like totally gone." Um, what would be your advice?
Yeah, I think so. It's like when I'm in the clinic or whatever, it's like we generally try and make like a little plan on things that which make it better and just figure out things which make it worse. And these things that make it worse, we might just put in our back pocket for now and we might not test it out. And we'll just like focus over here if it's like very recent for the low
Mhm.
back pain or whatever. It's like these things help my pain. It's like, okay, let's do more of these things. And then in the future, we might test out those things that were aggravating before, but they suddenly might not be aggravating now. Or if it's just, yeah.
So like establishing a baseline of where somebody's, having pain and
Yeah.
discomfort or particular movements that you can or cannot tolerate. So, like, would you call that symptom modification?
Yeah, it's symptom modification. But I think
Yeah.
simply or like putting in like nicer, more catchy words, it's like finding our base camp. What things can we do right now?
Yeah, and a lot of the things that you and I've talked about the last couple of weeks, just in our conversation, is like when people come in and they approach because I gave you kind of like a vague example. We want to know what people have done before we can even offer just like a smidge of advice because it's really just this is a we're only able to give a smidge of advice because it's general information. It's like if I was working with somebody who's tried, you know, all these different things, I'd say maybe try less. Maybe it's like we're putting too much emphasis on finding like the answer or like the fix. And so I kind of gave you a set you up, but I think um, knowing where somebody's at, you can always take them like you can always seems like you can always provide something that because when somebody's like, I've tried everything, there's probably something you haven't tried. I don't know if that started to make sense or I started to trail off because I'm thinking about like how do you get what's the best advice you can give everybody? And it's like you can't.
Yeah, I don't think you can. It's like so hard to because everyone is so different. And everyone's background's so different as well. It's like
Yeah.
it's like if one person's an athlete, what they've tried might be really different to someone else who's just like a stay-at-home mom.
Yeah. And also like what they need to do too.
Yeah, it's like the athlete might want to be able to get back to lifting heavy stuff if that's important to them. Well, for the mom, it's just like I just want to be able to pick up my kids and like run
Hmm.
around the backyard with them, right? So it's like very different things that they want to get back to doing, but
Yeah.
still they both really want to get back to doing these things.
Yeah.
And I guess it's like our job as like clinicians or like exercise or movement professionals to like figure it out with them, test things, and see what things work and see which things don't work.
Yeah. And I think if you're if you're on your own, and I'm trying to think like the most general advice you could give somebody is essentially it's like you're already pretty good at symptom modification, possibly. You're already like, well, sitting hurts, so I'm not going to sit a while. Um, but where you need a little bit of help is that like guidance on what's an acceptable level of pain because depending on your condition, whether it's just like a muscle strain or it's like radicular or like the nerve related stuff, you need to either lean into the pain and find what's like appropriate when it comes to like stiffness or just general strains and things like that. But if it becomes like that nerve type stuff, or you have that radicular category or the radicular syndrome, it's like, how do you not run yourself into the ground and just continually have flare ups? And that's, again, I think we've talked about this before. That's where it gets a little trickier.
Yeah, it's like pretty much it's like two sides of like what we as like clinicians try and figure out. It's like, does this person need, I guess, quote unquote, more exposure? It's like pretty much, do we need to practice these movements more, or do we need to be a little bit more protective because we're overdoing it? It's like we like
Hmm.
to push our limits because I'm an athlete. I always push beyond pain because I need to
Hmm.
win medals and stuff, right? It's like okay, maybe we need to pull this person back because they're pushing way past the limits and they constantly flare up.
Yeah. So
It's
if you
like,
find, so it's like if you find yourself, like if you're watching this, you're in the Reddit group and you're like, I am working with a PT. We have seen comments like this, and it's like this just making things worse. Just like take like if you have a moment where you're not having crazy symptoms, like take yourself out of the the struggle of dealing with that pain and just objectively look at what you're doing. And if it's like to like my normal day-to-day activities are flaring me up, there's a good chance exercise might be more than what you need. So it's kind of like it's a challenge for people, I think, just objectively look at their what they're doing and see if it's like too much because you just don't know. And I get it.
yeah, it's
Yeah.
hard to know if it's too much. And it's when we get into those scenarios of quote unquote doing too much, it's like, okay,
Hmm.
now we understand that there is like a too much zone. We have to kind of figure out where that zone is. And it's like turn that into a learning experience compared to like, oh my God, my life is gonna fall apart now because I'm flared up again.
Hmm. Mhm.
It's like
So,
now I feel even more hopeless. It's like I've made so much progress, but now I feel like I'm back to square one,
yeah. And
even
I
though it can be like such a good learning experience there.
yeah. And we know it's interesting. I so have like so far, I think next time we're over like like you're tired, I'm tired. No, the categories are like topics to talk about. We talk about posture, talk about disc bulging, talk about um, different strategies for approaching just regular stiffness and muscle or ligament strains. And then when it comes to radicular stuff, those are like totally different categories of talking about um, the because we've covered imaging. I think looking at like first steps on a, like a proactive conservative approach. I think these are all things that I'm just listing that we can talk about, in future lives. So anything else you want to share before we take off, because it's at 32 minutes?
Yeah, I think probably another thing that I think is super important is like actually understanding pain as well, instead of only
Hmm.
being proactive and not really understanding how our body slash like nervous system and brain and everything works. It's like, yeah, it's all interconnected. Because like we might be doing the right stuff, but if we don't really believe it, we might kind of just like nocebo ourselves into actually getting
Hmm.
better. It's like if you don't believe the treatment will work, then the treatment might not actually work because it's like, yeah, it's like you think this is completely wrong. So that's like a whole nother topic as well.
Yeah. All right, man. Well, you go get to bed because it's late in Australia, and we'll see you guys next time.
All right. Thanks, Andy.
Yeah. See you, Andrew.